My name is Jane Topple. I'm one of the radiologists here at East Sussex Healthcare Trust, sited at the Conquest site. And I'd like to speak to you today about CT perfusion imaging for acute stroke based on fellowship experience training I had in Canada in 2020. So this is Halifax Infirmary, which is the tertiary hospital which serves all of the province of Nova Scotia for neurosurgery and for acute stroke. It's probably something between the size of Eastbourne and Brighton. And, it's a busy place, not as busy as one of our central London hospitals. Most of us would think of Nova Scotia with relation to some of these things. So a Nova Scotian knows their way around a lobster. They know what to do with blueberries, and they like going to the beach. This is an image of Lawrencetown Beach on the top right-hand corner. And they make some phenomenal ice cream, but with some very strange flavors. This is something called Moon Mist, which incorporates grape, banana, and bubblegum flavor. I don't know, but somehow it does work. And Canadians know their way around a bit of snow. So Nova Scotia is a small province on the east coast. It has a population of about 1 million. The majority of people are dispersed around the province within rural areas, and there are many district hospitals within each of the satellite regions. Now, if you were to drive from Yarmouth down here on the south coast to Halifax, which is along the eastern shore, about the middle of the province, it would take you a good 6 or 7 hour drive to get there. And if you drove from Halifax up to the upper margin at Cape Breton, Nova Scotia, that would also take you about 6 or 7 hours to drive, weather permitting. So tip to tip, you're looking at a 12 or 13-hour drive to get across. So that's why they need lots of district hospitals. And the main 6 district hospitals use CT perfusion and have operating CT scanners to refer patients to the main hospital site. The Nova Scotia Health Authority realized that they were failing their patients with respect to stroke imaging way back in the 1990s after a large audit showed that their outcomes were well below that which was found elsewhere in Canada. So they founded a group which analyzed the data and worked to improve stroke imaging in the province. And what they created was a 24-hour thrombectomy service centered at Halifax Infirmary. There are 6 core neurointerventional radiologists and 4 neurosurgeons that staff that rota. They use helicopters and ambulance ground transport. There are 2 dedicated helicopters for the stroke service to fly patients from the various regions around Nova Scotia that you see here to the main site. And they have dedicated suites with a biplane fluoroscopy unit and also a single-arm fluoroscopy suite to carry out procedures. And with this service, they cover all of the province of Nova Scotia, but also the eastern half of the adjacent province of New Brunswick, as well as the entire province of Prince Edward Island, which doesn't have any neurointerventionalists on site. So the aims of this talk, I'm going to highlight the stroke service in Atlantic Canada, both its strengths and weaknesses. We'll use a case-based approach to CT perfusion imaging for acute ischemic stroke, and we'll discuss some of the benefits and downsides of perfusion imaging for large vessel occlusions. I'll also briefly discuss the evidence from clinical trials for the benefit of CT perfusion imaging, and we can hopefully have a discussion about future directions for stroke imaging here at East Sussex Healthcare Trust. So this is the NHS long-term plan with regards to stroke. They hope twice as many patients will receive clot-busting thrombolysis treatment, ensuring 20% of stroke patients receive it by 2025. And they hope 10 times as many people receiving clot-removing mechanical thrombectomy procedures will become the norm. Less than 1% of patients receive that treatment now, and they hope that it will improve. These are pretty low figures overall when you consider how many large cities staffed by neurointerventionalists we have here in the UK. There are definite benefits to the different modalities we use in acute stroke imaging. So the non-contrast CT head is brilliant at excluding hemorrhage and to pick up potential stroke mimics, such as mass lesions. CT cervical and intracranial angiogram is excellent to confirm large vessel occlusions by filling defects, which may be amenable to thrombectomy. It's very sensitive and specific for detecting large vessel occlusion at 98 to 100%. It's also helpful to assess the access in the neck. Do the patient have lots of atherosclerotic burden? Are the cervical vessels favorable to access a distal occlusion or not? And then we have advanced imaging such as CT or MRI perfusion. And this goes the next level up. It provides tissue blood flow characteristics, so we can assess the inflow arterially and the outflow on the venous side of the brain. We can see what the penumbra, or area of salvageable brain, is, the size of the core infarct, which is non-salvageable tissue. And this is really helpful in all strokes, but is very useful in patients with wake-up strokes where we don't know the time of onset. So the current imaging we're using here, the non-contrast CT head, great for hemorrhage or stroke mimics. Here you can see a patient who has low attenuation in the right periventricular region extending out to the cortex, which was a large right MCA territory infarct, and in the coming days they developed malignant MCA syndrome. Sometimes we use CT cervical intracranial angiograms, but it's usually on a case-per-case basis if we're concerned about basilar artery thrombosis or trauma with dissections. So these are the stroke transfer teams that they are using in Nova Scotia. This is one of the dedicated helicopter units. Obviously, they are very limited by wind, weather, and fog, of which there is a great deal in Nova Scotia. The winters are very long and they're very harsh. There's a particular storm called a nor'easter, which blows in from Newfoundland. It lasts for days and nobody can leave their homes. So this is the protocol that we use in Nova Scotia. The patient is assessed by the emergency doctors at the district hospital. Let's say that that is Yarmouth District Hospital. That district hospital is capable and able to perform CT perfusion imaging. They then send those images to Halifax Infirmary. The emergency physician rings the neurologist who is in charge of stroke at Halifax, who discusses the case, and both the neurologist and the interventional neuroradiologist on call that day review the uploaded images. If they feel, based on the patient's past medical history, current clinical findings and imaging, that they are for thrombectomy, then they instigate the stroke protocol. That patient is collected either by helicopter or ground transport, and they are taken to Halifax Infirmary. And at that time, the patient is reassessed by the stroke neurologist in the emergency unit. They may repeat the CT perfusion scan again, depending on how long the transport took. If it took more than 2 hours, then they will likely repeat the imaging again to see what the state of play is at that time. And these are all the district hospitals that are capable of CT perfusion imaging in Nova Scotia, and they are dotted around all of the main margins of the province so that you have good coverage for patients in rural areas. So they may repeat the CT perfusion scan on site at Halifax Infirmary, and then the treatment decision is made. If they are for thrombectomy, then they are transferred to the biplane fluoroscopy unit, and this is one of the machines that they have available there. To staff this room, you require a radiographer, 2 specialists, interventional nurses, an imaging assistant, the interventional consultant, and there's usually a fellow present as well. So, this is a big bit of kit and it requires a lot of staff to run it. So the computer-aided imaging analysis we use in acute stroke with CT perfusion, the non-contrast component helps to exclude hemorrhage, just like we are doing now. But the other components, the CT perfusion and the CTA, help us to identify patients who would most benefit from mechanical thrombectomy. And as I say, it can differentiate core infarct, which is irreversible damage, from penumbra, which is salvageable brain. And this is what you get with the CT perfusion scan. So we have our unenhanced head, we have our CT, cervical and intracranial angiogram with reformats, and then we have perfusion, which are 3 passes sequentially through the brain in rapid succession after the CTA, which shows us the inflow arterially and the outflow. So if you have a narrowing in an artery, the blood is going to take longer to get in, and the venous blood is going to take longer to drain out. So what you find is by the third pass, if you have veins that are hanging around, this is likely the region where the arteries are also narrowed. The computer program then makes calculations based on all of this, looking at the attenuation of the contrast in the arteries and veins, and from that, they make maps. The cerebral blood flow, the cerebral blood volume map, which you see here, and then this is collated to make a time to peak map, which is the one that you see here in green. From the unenhanced CT head, we use a scoring system called the aspect score, which is also useful, which I'll describe in the coming slides. So these are some of the measurements that the software is able to tabulate. The cerebral blood volume is the total volume of blood present in the region of brain, and that may be normal, elevated, or decreased. The cerebral blood flow is the flow rate of blood within a region of brain. And the time to peak is the time from beginning of contrast injection to maximum contrast concentration within a region of interest. Usually it's taken over the superior sagittal sinus or the torcula and one of the main vessels. And this is how the scan is actually performed. For those of you, or if radiographers are in the audience, you do the unenhanced head, you give a 40 milliliter bolus contrast injection, followed by a flush. At 60 to 70 seconds, you image the brain, and then you scan at cycles every 1 to 3 seconds, capturing the brain again on 3 sequential slices. And then you let the software set in motion to create these various cerebral blood flow, cerebral blood volume, and time to peak maps. And this is what the software looks like. This is how it calculates. The one that they used in Nova Scotia was called Rapid. There's another software called Olea, Brainomix. I think King's in London is using Rapid software. And a lot of these softwares are now being incorporated into the clinical trials, looking at CT perfusion to predict outcomes for patients with stroke who undergo thrombectomy. This is how the software picks the region of interest, getting the attenuation on the blood vessels, and then maps out the contrast density to tabulate the results. And Rapid software has been shown to have a 100% sensitivity and 91% sensitivity for detection of stroke. This is the aspect score that I was referring to earlier, the Alberta Stroke Program Early CT score. I'm sure some of you have seen this before in clinical practice. A normal CT scan with no evidence of stroke has an aspect score of 10. And then for each area of abnormality within the MCA territory of the brain, as you see here outlined, either in the basal ganglia region or at the cortex, you remove 1 point. So if you have an aspect score greater than 7, you are likely to do well and you are a good candidate for intervention. But if you have an aspect score less than 7, this is associated with worse functional outcome at 90 days and increased risk of bleeding post-TPA. So this is some of the guidance in the literature at the moment. NICE guidance suggests that brain imaging should be performed immediately, as soon as possible, within 1 hour for people with acute stroke if indicated. Now, I don't know if there are any neurologists or stroke physicians in the audience who have audited our service who can tell us, what percentage of our population we meet that target, but maybe we can discuss that at the end. The American Stroke Association is advising that CTAs are performed for patients deemed eligible for endovascular therapy for large vessel occlusion, and they are beginning to recommend CT perfusion and MR perfusion for these patients as well in the guidance. These are some of the indications for thrombectomy in large vessel. So large vessel occlusion, this would be internal carotid artery or the M1 segment of the middle cerebral artery. Patients with a small ischemic core on a non-contrast CT with a high aspect score of 8 to 10, they are eligible. Patients who have salvageable penumbra on perfusion imaging, or patients with tandem occlusions, so an occlusion of the internal carotid artery as well as a large vessel occlusion of the M1 segment. It's possible to treat both of those occlusions in the same sitting, and they are also recommended for thrombectomy. There are several trials that show benefits of the thrombectomy procedure. So the Mr. Clean, Thrace, Revastat, Escape, Swift, Prime, and Extend A trials all showed that there is benefit within 0 to 6 hours of symptom onset if the patient is favorable for a thrombectomy. But there are other trials that show there's even benefit for thrombectomy up to 24 hours after symptom onset. And the two trials that show that are the DAWN and the Diffuse 3 trial. The DAWN trial in particular highlighted the benefits of thrombectomy by selecting the patients based on the mismatch between clinical indexes of perfusion imaging using the baseline core volume. So they were using the CT perfusion software in the trial to determine who would be suitable for thrombectomy, and that showed there was advantage of this procedure up to 24 hours when CT perfusion was used. And what predicts a good outcome for our patients who have thrombectomy? Well, those that have a short door to scan time and then a short door to needle time usually do well. And this is a problem in Nova Scotia where the distances are so far and where the weather is so unpredictable. Obviously, our distances here in East Sussex are much smaller, but our congestion is greater. The roads can take a long time to traverse. Patients who have good collateral vascular supply in the brain found on CTA or perfusion imaging tend to do better than patients who are rapid progressors who have poor collateral blood flow. And this is something that the CTA can identify with perfusion software, but that an unenhanced CT cannot. Patients who have favorable cervical vessels, which are non-tortuous with no loops and no tandem occlusions, tend to do better at thrombectomy. And those with good access at the groin arteries and aorta. Obviously, if you've got diffuse atherosclerosis or aortic occlusion, it will be challenging. You would have to do direct puncture of the carotid artery, and for that, you'd need vascular surgeons on hand to close at the end of the procedure. The volume of the core infarct will correlate with the patient's outcome. These are some of the contraindications, both in the clinical trials and at Halifax Infirmary in the Nova Scotia Stroke Service. So patients with advanced dementia are not eligible, those with a history of incurable cancer, or those who have undergone recent major surgery or had recent major trauma. Patients with poor vascular access are those presenting beyond 24 hours of symptom onset. And then small distal branch occlusions of the M2 or M3 segments of the middle cerebral arteries. There's no evidence in the clinical trials that those patients benefit from thrombectomy because the technical challenges of the procedure make complications much more likely. And then patients with very poor collaterals are unlikely to make a long journey, and they are not considered eligible. They're unlikely to benefit. So let's move on to some of our case examples. So case 1, we have a 57-year-old male who collapsed at work and has right hemiplegia. What we see on the unenhanced CT head, there's no hemorrhage, no hydrocephalus or mass. We've got some patchy areas of low attenuation here in the periventricular and periopercular regions and just along the external capsule. And when we do the CTA, we can see that there's a very large occlusion of the M1 segment of the middle cerebral artery. So the unenhanced head really didn't give the game away, but the CT perfusion is incredibly helpful. So this is the cerebral blood volume and cerebral blood flow maps. You can see that there's this large defect, which is fixed in the left MCA territory. And when you look at the time to peak map, this is showing you the black is core infarct. This is unsalvageable brain. The ischemic penumbra, which is salvageable brain, extends much wider, almost to the parafalcine frontal region anteriorly and to the junction of the occipital lobe posteriorly. So this is a very large infarct due to a proximal occlusion. Unfortunately, the patient had poor collateral flow, so they were not considered a good candidate for thrombectomy because they would be unlikely to make the journey and with such a large core infarct. So they were for best medical management at the local stroke center. Case number 2. This is a 76-year-old with left-sided weakness and aphasia. On our unenhanced CT head, we can see there's no hemorrhage or mass. There's a small wedge of low attenuation along the external capsule on the right, giving us an aspect score of 9, which is favorable. When we do the CT perfusion, the cerebral blood flow and cerebral blood volume maps show no fixed match defect. When we look at the time to peak and the CTA, we can see there's a small occlusion within an M2 branch of the right middle cerebral artery with a corresponding area of penumbra or salvageable brain here within the right parietal lobe. Unfortunately, the patient had very tortuous and calcified neck vessels with loops, and the interventional neuroradiologist felt they would be unlikely to succeed in getting up to the area of occlusion. Because it's a M2 rather than M1, the literature does not really recommend it because of the increased risk of complications. So the patient was for medical management. Case 3. 67-year-old with extremity weakness, right-sided weakness, and facial droop, slurred speech, but they do improve in the department in emergency. Our unenhanced head is completely normal, no low attenuation and no hemorrhage, so the aspect score is 10. We have our cerebral blood flow and cerebral blood volume maps. There is no abnormality, no matched or fixed defect, and the time to peak map is normal. The CTA component shows no filling defects or stenoses, so it's a normal perfusion scan. So this patient likely had a TIA, and they were referred to the TIA clinic. Case number 4, 59-year-old with right-sided weakness of sudden onset. Our unenhanced CT head excludes hemorrhage, and there is a focus of very low attenuation at the corticomedullary junction along the precentral gyrus. We then go on to do our perfusion imaging. There's a match defect here in the left frontal lobe anteriorly, suggestive of ischemia. Then we look at our CT angiogram. We have a large and long filling defect occupying the M1 segment of the MCA, suggestive of thrombus. And our time to peak map shows a very large wedge of salvageable penumbra of the brain. So this patient is considered a good candidate for mechanical thrombectomy. It's a proximal occlusion. There's salvageable brain with not a large core infarct, and the neck vessels were favorable. They were transferred to the angio suite and anesthetized, and using this penumbra suction device, the clot is retrieved. And the procedure was complicated by a small dissection, but they had good distal flow. And this was the follow-up CT at 24 hours, showing no residual infarct. And the patient remained well on follow-up. Case number 5, 45-year-old with loss of vision and confusion. Our unenhanced head shows that there is a thin wedge of low attenuation in the occipital lobe, suggestive of a posterior circulation infarct. And the time to peak, cerebral blood flow, and cerebral blood volume maps tell the tale. So there's a non-matched defect here within the occipital lobe, which you can see on the cerebral blood flow, but not the cerebral blood volume map. And there's this area of mixed ischemic penumbra with small areas of infarction here within the left occipital lobe. So the patient is unlikely to benefit from thrombectomy because there really isn't any literature currently that shows that posterior circulation infarcts benefit from thrombectomy due to the high risks of the procedure within the posterior circulation vessels. But also, this is a P2 occlusion, it's not a proximal vessel, so the patient would not be a candidate there for best medical management. Our next case is a 75-year-old with a past medical history of lung cancer. He was a wake-up stroke with leg weakness. At the time of onset is unknown. The unenhanced head shows some patchy low attenuation beneath the cortex in the paraphosine right frontal lobe. The aspect score was considered 9, and he had an old infarct in the right parietal lobe. The CTA component of the study showed that there was a possible small distal occlusion in the closomarginal branch of the anterior cerebral artery. He had poor access in the neck. The cerebral blood flow and blood volume maps are beginning to show a matched defect here within that frontal lobe, and there's an area of ischemic penumbra, which is salvageable brain in the paraphosine frontal and parietal lobes. But because it's a distal occlusion of a small vessel with poor access, the patient is not for thrombectomy. Case 7, 56-year-old with confusion. Our unenhanced head is normal. Aspect score is 10. There's no hemorrhage. The cerebral blood flow and cerebral blood volume maps are unremarkable. The CTA shows that there are a few veins which are just hanging around here within this left temporal parietal region. And you can see on the time to peak map, there is a small wedge of salvageable penumbra at that location. So it's a distal vessel, likely an M3, and it's not for thrombectomy, and the patient was for best medical management. Case number 8 is a 74-year-old patient presenting within 2 hours of onset of left hemiplasia. The unenhanced head is pretty blameless. We can't see any hemorrhage, mass, no low attenuation. The basal ganglia structures were normal, but the CTA really shows the tail. We've got complete absence of opacification of the right middle cerebral artery and the A1 segment of the anterior cerebral artery, suggesting a T occlusion. And when you see the CTA component here, there's complete lack of all of the small vessels throughout the right cerebral hemisphere, as you would see normally on the left-hand side. And this suggests that this patient has very poor collateral blood flow. This is also highlighted here on the 3 sequential passes through the brain. You can see that the veins are hanging around here in this right cerebral hemisphere. There's really very little vascularity at all. And this is what we call a rapid progressor. So the patient has an occlusion, but they have poor collateral blood flow. So the area of ischemia progresses very rapidly, incorporating the entire MCA territory. There's a fixed defect on the cerebral blood flow and cerebral blood volume map, which is almost entirely made up of core infarct with very little penumbra. So this patient is not for thrombectomy because there's really very little salvageable brain, and they would be unlikely to survive the transport. And it's pretty remarkable that the unenhanced head doesn't give this away at all. Because if you're not considering perfusion of the brain, inflow and outflow and collateral supply, you really have no idea what's going on here with this patient. And I think that this imaging really shows you what's going on and helps you to make decisions. So here's an example of a patient I saw recently. It was a 63-year-old male with acute onset of left-hand weakness, loss of vision in the right eye, and aphasia. And he underwent a CT head at the time, which was normal. And then 2 days later, he had an MRI scan, which showed good flow voids in the vessels, but showed that there was some small embolic infarcts in the right cerebral hemisphere. So he then returns to the hospital with left-sided weakness. He has another CT head, which is again normal, no hemorrhage, no large infarct. And this is the second MRI, which is performed 2 days later, which now shows that the patient has loss of the flow void within the petrous, cavernous, and supraclinoid segments of the right middle cerebral artery, suggesting complete thrombosis. And this was not present on the first MRI. So it's likely that the patient had had a spontaneous carotid dissection at the time he had the embolic infarcts. Now, if we had performed CTA at that time, we may have caught that abnormality. Perhaps we would put the patient on different treatment. Perhaps he may have been referred differently. And so now this patient is at risk for further clots in the acute setting. So there are some uncertain areas with respect to thrombectomy. Obviously, the benefits of thrombectomy in those presenting after 24 hours has yet to be discerned with clinical trials. Posterior circulation occlusive strokes. There is no evidence of benefit from thrombectomy compared to medical management currently based in the literature due to the high complication risk. But some centers are using decisions on a case-by-case basis, using informed consent with patients to make those decisions, whether they proceed or not. In patients with brainstem, internal capsule, and deep white matter lacunes, those can be falsely negative on the CT perfusion software. The downsides of this service, it takes a lot of time. You've got neurologists and neurointerventionalists running to the CT scanner for every stroke that comes in to look at the perfusion scan and analyze it. It requires a lot of training and staff, and there's the radiation burden when you're scanning the patient maybe twice before making the decision. you'd have to put that against the risks of large ischemic penumbra, which is salvageable brain in a young patient, the costs to the healthcare service of that patient with a disability if no treatment is provided, the medical management fails. So do we think that CT perfusion imaging might benefit patients in East Sussex? Well, it could help differentiate which patients could be transferred to Brighton for thrombectomy and which could be offered best medical care at the DGHs. Brighton is currently offering a sporadic thrombectomy service. As of the autumn, they'll have 2 more full-time neurointerventionalists on staff, and from then they will be able to provide an 8 a.m. to 8 p.m. service 5 days a week for thrombectomy. They are currently limited by getting specialist nursing and radiographer staff to carry the service, but they are headed that way. And the goal is for them to provide 7-day-a-week, 24-hour thrombectomy service once they are able to provide that. So the decision to transfer and perform thrombectomy would be made by the interventionalist on call accepting that patient. So in theory, as long as we were performing the imaging, it could be reviewed by that person. It wouldn't need to be reported immediately on site out of hours. It could be reported during the day. The importance is that the scan is available for the decision to be made within 24 hours. So if we're not going to use perfusion imaging here, should we in the least be adding a CTA to our stroke protocol to provide more information about large vessel occlusions and collateral blood flow in our patients? This is just a reminder of all the different types of imaging that were previously used to look at one of our favorite diagnoses in the hospital, pulmonary artery embolism. So this chest X-ray shows a Westermarck sign, which is translucency within the right hemithorax because the amount of blood flow there is reduced due to a large blood clot within the main pulmonary artery. And then for many years, the gold standard was to use VQ scanning, where you have wedge-shaped filling defects here. And then obviously the current gold standard is our CT pulmonary angiogram, where we can see the clot, we can see its extent, which vessels are involved. And so I think using angiography really is the way forward. I mean, why would you look for clues of a clot if you can see the clot itself? And I think with stroke imaging, it's exactly the same thing. Why use just an unenhanced head for clues of a stroke if you can see the clot, you can see the perfusion, you can see the collateral blood flow using CT angiography or perfusion imaging? There are examples in England of where trusts have instituted a thrombectomy service, and there were cost savings, although it is an expensive service to set up. So in conclusion, CT perfusion imaging can distinguish core infarct from ischemic penumbra in the brain. The unenhanced CT head is ideal to exclude hemorrhage or stroke mimics, and it allows us to give the aspect score, which is useful in trial evidence. The CTA cervical and cranial scan can identify a large vessel occlusion or a dissection and can give us information about vascular access. And this technique is helpful to triage patients with wake-up strokes and to aid determination of which patients are suitable for thrombectomy and transfer, which I feel is coming to our trust when Brighton are up and running with their thrombectomy service. I've given you all of the references of the clinical trials that I've mentioned as well. And I just wanted to open it up to discussion for any thoughts. Do people think that it would be a good idea to have CT perfusion imaging here? Do we think that we're going to get the stroke thrombectomy service up and running? What are everyone's thoughts?
Hi, hi, it's Barbara, one of the stroke doctors from Eastbourne, actually. Hi, it's fantastic. It was fantastic presentation. Thank you very much, Dr. Topple. It was brilliant. And coincidentally, we had a chat today, and we were setting up pathway for CTA to start, as soon as we have the pathway set up. So for patients who are eligible for thrombectomy in hours, who we can offer that service, then we will sort of do automatically CTA. I think one of the inclusion criteria is also like the NIHSS score, which is more than 6, and
Yes.
not sort of, if they are improving, they are unlikely to be accepted, which is understandable. And I think another one is the modified ranking score, pre-morbid modified ranking score, which is less than 3,
Yes.
hypothetically, and I think they are sort of accepting more below 2 than 3, which they are fairly independent, individuals. So that just to add on to,
Yes. That's really
yes,
helpful. Yeah.
yeah,
I know we do
yes.
have CT perfusion software available on our scanners at Eastbourne, so we
Oh
do
wow,
have the
okay.
facilities to use it.
And I
It,
think we, sorry.
go ahead, go ahead.
No, okay, yeah, no, you go ahead. Sorry.
So it's something that we could start using if all of you thought it would be a benefit. I mean, it's all well and good if I think it's a benefit to distinguish the penumbra from this, core infarct, but it's whether you would find it helpful or not. But what I can say is the software package is already available on the scanner at Eastbourne, so it would be possible to do this imaging now.
Okay. Yeah, that would be really helpful. I think we haven't sort of discussed that yet, because then it will raise the issue who's going to report it, as well as the CTA reports and stuff. But
Yes.
yes, it's helpful for Brighton, interventionists to have that available. So yeah, it's
I think they
probably,
would in the least need that to make the decision whether to
yeah,
transfer the patient.
absolutely.
I mean, personally, I think looking at an unenhanced head, there are some subtle nuances. It can be very difficult to pick up an early stroke in a patient with good collateral flow. But I think the time to peak map, it's pretty clear. I mean, once you get used to seeing them and you have
Yeah.
a familiarity and the training with it, I think it's much easier to interpret that than it is to interpret an unenhanced head with less years of reporting experience.
Yeah, I agree. Yeah, that would definitely be a huge benefit. That was my question. You had the last case with the rapid progressor, and you
Yes.
mentioned the slow, sort of low collateral flow. So one first question is, what is the time between the plain CT and the CT perfusion? Because
Seconds. Seconds.
seconds. Oh wow.
They
Okay.
happen at the same time. You do the unenhanced head, you then immediately do the injection, you do the CTA cervical and intracranial angiogram. Then there's 3 more passes through the brain to look at the inflow and outflow of the venous blood. And then the software package takes 5 minutes to make the cerebral blood flow, volume, and time to peak maps. So it's
Uh-huh.
all done within 10 minutes.
Okay, so it's very interesting that the plain CT was absolutely normal, and then within few seconds, then there is a large area of infarction, which hypothetically thinking, if we only have that plain CT and we thrombolize people, with that sort of low collateral flow, and they
Yes.
already have a big infarct,
It's high risk, right?
it's definitely high risk. Yeah.
And if you don't have the perfusion imaging, you really don't know what you're dealing with. It's like
Mm,
trying to prove the, pulmonary embolism using the Westermark sign on the chest X-ray, or it's just not as good. It's not
mhm.
as sensitive. It doesn't provide as much information.
Yeah, thank you. That's really um a good idea to implement the CT perfusion. And yeah, as you said, that it's not science to great science to get used to reading it, if we're
I don't
doing
think
it
it
on
is.
daily basis, really. So
I
yeah.
think, and there's several of us here in the trust, I think, who are familiar, and I'm sure we'd be happy to run training
Hmm.
sessions for anyone if we all decided that we wanted to start using the software package.
Fantastic. Yeah, that would be perfect.
Any other questions or
Thank you.
comments? I can see a hand raised. Please do just shout out.
That was my hand.
Okay.
Sorry.
Anyone else? Anyone else? Okay, I'll just log off then. Thanks again for having me. And perhaps we can all organize a meeting or a discussion on the stroke service to carry this forward. That would be great. I'm always contactable by email. Have a good day.
Perfect. Thank you. Have a good day.
Bye-bye.
Bye.
Thanks so much, Jane.